Hey guys, this session is a session on environmental emergencies, heat emergencies, cold emergencies, and some issues to do with water like drowning and decompression illness. So let's have a quick look at this. There's a few slides in it, so we're going to pop through this. It'll probably take us about 40 minutes or so. So lesson topics: heat-related emergencies, drowning and decompression illness. So heat-related emergencies being hot and cold. We're going to have a quick chat about wet and dry drowning, and then decompression illness with diving. Lesson objectives: so how do we regulate body temperature, hypothermic emergencies, hyperthermic emergencies, water-related emergencies, and decompression illnesses, or DCI. So what's normal body temperature? So what is it, guys? 34, 35, 36, 37. Normal body temperature is 36.9. We get concerned at temperatures below kind of 35, 36, 35, and we get concerned about temperatures over 38.3. So how do we generate heat? So how do we generate heat? Number of ways. Muscular activity, bit of moving around. All them muscles are generating lots of energy, which generates heat. When we're digesting food, you've got the meat sweats before and stuff like this. Large meals, your liver works overtime. The likes of peristalsis, which is the snake-like movement of your digestional tract. There's a 25-foot kind of length of muscle there, which is doing this movement, this intrinsic movement, which is generating heat. So in general, muscular activity in general regulates heat. Muscle contractions, more strenuous activity, the more heat produced. Biochemical reactions, like the liver is very chemically active. It's the hottest organ, biggest organ of thermogenesis, or temperature generation within the actual body itself. The digestive organs, heat produced during peristalsis, which is that kind of snake-like movement of the digestive tract itself. So your body tries always to balance. It's always about homeostasis. Homeostasis being balance. Okay. So heat loss and heat gain are always kind of balanced to get us to that kind of magic 36.7 or thereabouts. So it's within this kind of, I suppose, narrow confines of these temperature bands that what goes on in our body happens best. So temperature needs to be controlled. We operate best, the chemical reactions in our body happen best between very, very narrow temperature ranges. Our body pH or acid-base balance happens within very tight ranges as well. Everything is always to facilitate this homeostasis. Okay. So the hypothalamus is an area, just sits at the base of the cerebrum. And the hypothalamus has a number of functions, one of which is temperature regulation. So it's very sensitive to change the temperature. It's circulating blood. Young children don't really have this mechanism intact until they're about three or four. I think we've mentioned this, which is why they're very predisposed when they get sudden rises in temperature to febrile convulsions. The medulla oblongata, as we know, in the brainstem controls the diameter of blood vessels. So it will dilate blood vessels near the skin to bring big blood flow to the surface to liberate heat. Because remember, to conduct heat around the body, it's actually the blood that conducts heat around the body. So, you know, large organs who are generating a ton of heat, like your liver, big blood flow through the liver carries heat away from the liver to enable the cells in the liver again to sit within kind of normal temperature ranges. So there's a couple of things connected together here. The hypothalamus and the medulla intrinsically work together to facilitate blood flow from areas of heat within the body to the skin, so we can actually dump this heat. Exposure to cold. So heat loss and heat gain are always kind of in balance to try and maintain homeostasis. Hypothermia, general cooling. So it's defined as a state in which individual's body temperature is reduced below normal. So it may be general or local. And by that we mean generalized cooling would be where we have, our core temperature is cold. So our whole body systemically, our temperature is down. As opposed to you put your hand onto something like a frozen metal, you put your hand on that for a couple of minutes, you can get a cryogenic burn, you can get a thermal burn, which is a cold burn as well as a hot burn. This area here would be the area that would be locally cold. Having your hands exposed on a really cold day in your face, your hands and face would be like particularly freezing, but the rest of your body is warm. That would be localized cooling. So the most at risk are always the same, the young and the old. So infants, because they don't generate a whole lot of heat themselves. They don't have much muscle mass. The elderly are the same. They tend to lose a lot of muscle mass. They don't have a huge amount of fat, and they tend not to be very, very active, so they don't generate tons of heat. The other thing they've mentioned here, I think, is alcohol. People involved in outdoor activities and alcohol. Alcohol predisposes you to reduce temperatures. A lot of people walking home from bars at night sit down to have a rest, you know, and in cold weather they end up dying. You know, it predisposes you to hypothermia, alcohol does. Again, this is your typical scene. An old person who may or may not have they may not have central heating, they may not have the money to actually turn their central heating on, and they have these 1 and 2 bar electric fires which generate crap heat, and they're sitting there for as many hours of the day as they have electricity on the go to be able to heat themselves. You know, they live alone, they have poor heating, poor nutrition, so they're very predisposed to hypothermia. So how do we lose heat? How does it happen? How does it happen? I mean, inside we're generating a lot of heat. Again, as I mentioned, the blood carries heat away from areas of heat and it dumps it. It liberates it. So blood vessels dilate close to the skin and allow us to dump our heat, which gets evaporated off, particularly with the likes of wind and stuff like that. So, conduction. Direct transfer of heat from one body to another. So somebody lying on cold, the likes of snow, somebody in cold water, cold flowing water in particular. So heat flows from higher to lower source of heat. Water conducts heat away 25 times faster than air. So somebody in water, particularly moving water, is going to lose heat 25 times faster than standing there with no clothes on and just air. Okay? It's conduction. It's direct heat to cold, taking energy away. This guy here is going to get cold very, very quickly. Evaporation, so your body perspires or gets wet. As it does, the warm air, the air gets warmed as hot blood comes close to the surface. As we sweat, the sweat then gets cold as the cold air interfaces with it, and has a cooling effect. 75% humidity will lose 100% per day. 100 mils per day, should I say. So 75% humidity will lose 100 mils per day, and that's in 75% humidity. That's pretty warm. You go somewhere like Ireland where it's really, really cold, and you lose a lot more water per day because we're evaporating sweat off us. Okay. Convection, so where currents pass over the body carrying heat away, aka wind chill. So, you know, it may be a cold day, but if we have a kind of 25 kilometer per hour wind, we then get wind chill, which takes heat almost like flowing water. It takes heat away from us like at a much, much faster rate, guys. External respiration, when we blow out and you see this fog form, you know, air inside of our lungs is warm. It's warm from pulmonary blood flow. And when we exhale, we're actually exhaling heat as well as carbon dioxide. So heat loss is a result of exhaled air. It depends on the rate and depth, about 300 mils per day. Yeah, absolutely. Radiation, so, you know, radiation is energy traveling in straight lines. Heat loss in the form of infrared rays. We lose large amounts of heat from our heads. All objects radiate heat. Internal heat is naturally just radiated in straight lines. Okay. How we react to cold, so heat preservation. We vasoconstrict. We get piloerection, pilo being hair. So the hairs on your arms stand up if you have loads of them, especially if your mammy knitted you. Yeah. You start to shiver. Thermogenesis. So when we shiver, what do? We're starting to generate heat from muscular activity. Chemical release, which increases your metabolic rate, which is epinephrine or adrenaline. So adrenaline automatically gets dumped, heart rate kicks up, and we start to kind of move a little bit more and generate more heat. These are the natural reactions to kind of losing heat. Shivering, thermogenesis, skin is cold to the touch, signs and symptoms, decreased motor function, stumbling, drowsiness, irrational behavior. As hypothermia, you know, develops and starts to deeply affect what we're doing, you know, we start to see the manifestation of decreased motor function, stumbling, drowsiness, and irrational behavior. People get tired. Mumbles, fumbles, and stumbles, they talk about it as. So slow, shallow breathing. Slower pulse, which could be below 40, and again, it's quite difficult then when we're taking pulses of people who are cold. Blood vessels have constricted because the body is cold, which means, you know, peripheral pulses are difficult to get, and when you do get them, pulse rates have dropped significantly, so they're a little bit harder to feel. So we need to give longer to assess pulses than we would do normally in somebody who's warm. Patient will be pale, maybe some cyanosis at the extremities, and the reason they're pale is blood flow has been shut off to the peripheries. And it's being shut off because the body is trying to maintain heat and keep it in the core. Yeah. Gradual loss of consciousness or an altered level of consciousness is quite common as hypothermia progresses. There's a CPG on hypothermia here for your EMTs. And again, the red boxes are what we need to know. Some members of rescue teams should have a clinical leader of at least an EF4 level for those of you involved in the likes of mountain rescue and things like that. Hypothermic patients should be handled gently and not permitted to walk. There's a lot of products of cellular respiration knocking around, lactic acids, potassium, stuff like this. We need to be taking these patients and we need to be actually transporting them. They do not want to be walking. Okay. Pulse checks, 30 to 45 seconds, typical question. Have a look at the CPG yourselves, guys. Okay. Yep. So, transport. In a helicopter, transporting them head forward. In a boat, you're transporting them head aft. And what you're doing by that, as a helicopter is flying away, if you have them head forward, you're promoting cerebral blood flow. And again, if you're in a speedboat and the boat is traveling fast this way and the head is aft, you're promoting cerebral blood flow. These things here, these form questions that they ask in the FEC exams all of the time. So you need to be having a good look at these. Space blankets, so passive rewarming, so normal blankets first, and then these space blankets, these foil blankets we put around. So it's about having, fabric close to the skin and then the space blanket around it. They never go directly onto the skin. Okay. Active rewarming, so it's not really something that we do pre-hospital per se. We can do for somebody who's cold if we have a hot drink maybe. Active rewarming, used in hospitals, maybe help by ALS support. Pre-hospital, warm oxygen, warm hot water bottles if you have them against the skin, warm IV fluids and warm air on the body. So warm air, these Huggy Bear things they put on them. Warm IV fluids is something that your advanced life support clinician should have. I keep them on the window of the dash of the ambo with the heat on them. And if somebody's cold, fluids that are going into them are going to lift the temperature a little bit rather than drop it. Okay, so a warm ambulance en route. So think about that. Turn on the heating. The only downside is when we open all the back doors, all the bloody heat runs out. However, having that heater warm and generating a lot of hot air before we get there, it makes sense. Provide basic life support. Focus medical history, sample history. Remove from the cold environment is the big thing. Remove wet clothes. And again with dignity if possible. Any wet clothes need to come off because what we're doing is we're just simply conducting heat away from the body faster if they're left in wet clothes. So strip all the wet clothes off and get them dry, and then start putting blankets around them. And if we have warm water bottles, have them in the layers of the blankets. If they're getting IV fluids, make sure they're warm. Stuff like that, yeah. Monitor the patient and reevaluate clinical status. Reevaluate after you do any interventions. If you have a nice warm environment for them to sit in where they're maybe taking in some oxygen and stuff like that, you should start to see a rise in levels of consciousness, for particularly people who've been in a cold environment for long periods of time. Some critical concepts, so 3 different levels of hypothermia. We talk about mild, moderate and severe, and this is something that you need to know, guys. So mild is between 34 to 35.9, that's considered mild. And that will be most of us during the winter time if we're not doing heavy exercise and we're out in public. Moderate between 30 to 33.9, and severe is below 30. So, between your normal body temperature 36.7 or 36.6, down as far as 36 degrees. Once you start dipping under 36, you're mildly hypothermic. Once you start dipping under 34 degrees, you're moderately hypothermic, and when you're below 30 degrees, you're severely hypothermic. Okay, and we kind of like to drop them into these little these 3 little things. So allow 30 to 45 seconds for breathing and pulse checks. Why? Because in general your respiratory rates and your heart rates tend to drop when somebody is very cold, and it can be quite difficult to spot, and we need to be mindful of the fact that if we do it really quickly, we may not have accurate pulse and respiratory checks. These people, when they get particularly cold, when they get severely hypothermic, can arrest. We can have cardiac arrests. So we need to be mindful of taking vital signs and making sure that they're accurate. Avoid rough movements and excessive activity because it may trigger a VFib, a ventricular fibrillation. You got to remember the normal mechanism with regards to minerals such as your sodiums, your potassiums, your chlorides, and their calciums and stuff. They're going to be all over the place, and rough and Nasty handling can actually just knock the heart into a VF, which is very easily done. Remove wet garments by cutting. Yeah, get all that wet stuff off. If we don't, the patient's going to continue to lose heat, even though they're maybe in a nice warm ambulance. If they've got cold clothes on them, there's no way that they can start to warm up. 90% of hyperthermic patients have an elevated blood alcohol level, which is really interesting. So, check blood sugars as well, check blood glucose levels. That can also induce hyperglycemia. Alcohol has many negative impacts, and when we start throwing environmental stuff in on top of the likes of sugars and that, we can be in big trouble. Local cooling, defined as injuries which affect a particular local part of the body, so they may present as frost nip or frostbite. We don't really get a lot of frostbite here. We can have some serious injuries with them. Frost nip, very minor skin damage with complete recovery. Nose, ears, fingers and toes are the usual problem areas. Yeah. So affected area stings and then goes numb. And again, we're starting to get tissue death then, because there's no blood flow to this area. Okay. Blisters may appear in the skin, also called superficial local cold. Yeah. Don't get too. So there's a superficial local cold injury. There's a clear demarcation line, as you can see there, with regards to where the injury actually is. Sorry, excuse me. There's a clear demarcation line there. So everything in there is got a superficial local cold injury. You can see the colour, and the tissue is, a lot of that tissue is dying. Local cold injury, there you go. I mean, that's pretty nasty. A blister, it actually looks like a burn, and it is in terms of, it's actually a cryogenic burn. It's a cold temperature burn. Right nasty injury, particularly a thumb there is really, really nasty. Local cooling, frost bite and freezing usually develop if frost nip goes untreated. The skin and subcutaneous layers of muscles and bones all become frozen. The skin looks waxy and clear, and it's got these clear demarcation lines we mentioned earlier. It's a real emergency, also known as deep local cold injury. And I think there's one here. There you go. So you can see that there's death and necrosis of that tissue, and I'm going to lose the end of them toes, if not all of them themselves. This tissue is actually dead. Liquid nitrogen, a cryogenic burn. So again, it's not always about heat. That tissue is, they've lost a significant amount of tissue, and it's right down into the dermis, as you can see there, which is nasty looking. So treatment, provide BLS, always BLS, ABCs, airway, breathing, circulation, always. Focus medical history, sample history, absolutely. Primary survey, secondary survey, always. Always the same stuff, and then a set of vital signs. Remove from the cold environment, remove any wet clothes, passively rewarm. Monitor the patient and reevaluate clinical status, reevaluate of any intervention. So you have your basic life support, your ABC, your medical history and sample, then kicking into your secondary survey, your set of baseline vitals. Maybe you're giving them some oxygen, getting them, kind of passively or actively warm if you have that option. If you have ALS there and they need to get some fluids, you might have some warm fluids going in. All the wet clothes got to come off and start the process of heating them up. Focus medical history questions. So, where were they? What kind of an environment? How long were you there? Did you have a loss of consciousness? The effects, are they local or general? Are we going to potentially lose the end of fingers and toes? Things like that. Remove jewellery if possible, because again, with cold injury we can get swelling. With swelling, if we have rings or stuff like that on, we can inhibit circulation and we can end up losing parts of the body we want to kind of hang on to. So rings, if they're there, take them off. Jewellery. Dress limb if necessary. So if there's open injuries like what we've witnessed there in some of the pictures, you need to dress them because we need to protect them from infection. Never rub the affected area, because what we may very well do is rub meat off. Okay. Passively rewarm the patient and the affected limb with warm blankets and a space blanket. Material blankets first and then the foil blankets on the end. Turn the ambulance heaters on. Very important. Very important. On the other side of the equation then, we're looking at heat-related injuries. And there's a couple of bits in this. Here is the CPG. For heat-related emergency adult, there's quite a bit in it. We talk about do not overcool. The first thing is obviously to cool people, remove clothing. But if we overcool, we may induce hypothermia, so we need to be mindful of that. So what we do is we always cool the area that's hot, but we don't really want to cool them that much. Remove, protect them from the hot environment if it's safe to do so. Check their blood glucose level and cool them down. So exposure to heat defined as a state in which the individual's body temperature is elevated above normal. And again, we mentioned our normal as kind of 36.7 or thereabouts. The most at risk, firefighters, particularly in the likes of the United States, they have a lot of deaths from overexposure to heat for long periods of time. Long periods of sunshine definitely doesn't happen in Ireland, so we don't have to worry about that. Excessive physical exertion and medications and drugs such as ecstasy, which both inflate your metabolic rate and dehydrate you at the same time. Three main presentations: heat cramps, heat exhaustion, and heat stroke or heat syncope, which is a true emergency. Heat cramps themselves, so heavy perspiration with a loss of salt, and this is fine. Once we're perspiring, it means that we haven't lost all of our body fluid. So once we're still sweating, it means that our mechanism for cooling down is still actually intact. Okay? We lose salt when we sweat heavily. Prolonged exposure to heat, we drink some water, lack of salt in your system, cramps in the abdomen and legs, total body weakness, heat cramps. Overexertion will lead to heat cramps. Heat exhaustion, so prolonged exposure to the sun with heavy perspiration and a loss of salt. Person doesn't drink any water, so what we're not doing is refilling the reservoir. Lack of salt and water in your system, fast heart rates, fast breathing rates, temperature usually over 38. So, this is somebody who's lost a lot of fluids and salt. Treatment, call ALS, provide your usual basic life support. Your secondary survey involves your sample history, your set of vital signs. The real thing, get them out of the hot area and cool them down. So remove from the hot environment and remove their clothes. Monitor the patient and reevaluate their clinical status. Reevaluate any interventions. So, if you start to cool them down, just make sure you recheck the temperature a number of times, because what we don't want to do is drag them out somewhere where it's cold and actually send them from a hyperthermic to a hypothermic state. Passively cool the patient, so lukewarm water. There's some water on their body and stuff, it doesn't have to be cold. Just water in general will facilitate the blood flowing under that skin to actually dump a lot of its heat. Transport as a trolley, on the trolley, and if fully alert, give them something cold to drink. If they're fully alert, give them fluids because they've lost a ton of it. Okay. Heat stroke, temperature regulation system fails. So the patient ceases sweating. So hot, dry skin is the kind of typical presentation. Hot, dry, red skin. And the reason why they're hot, they've no fluids left to dump. So, your thermoregulation system has failed. Fluid and salt problem, they're both gone. Mild form of heat stroke is called sunstroke. Temperature usually over 40, and this is a true emergency. Usually, certainly an altered level of consciousness or unconscious, rapid weak pulse, rapid panting. The body is trying to compensate by pumping everything really, really fast. Headaches, dizziness, dry, hot skin. The dry, hot skin is the real that's the key. So treatment, again, call ALS, provide your BLS, your ABCs, get your secondary survey done, your sample history, and your set of vital signs. Get them cool. Get them out of the warm environment, strip them down, monitor the patient, reevaluating clinical status, reevaluating interventions and cool them down. You need to get rid of that heat. The heat is the problem. They can no longer manage their own heat. They're in trouble. So we're talking about those heat emergencies, either hot or cold. When we get to a situation where we're operating outside of our safe parameters between 36 to 38 degrees, typically hotter than 38, lower than 36, we're starting to get into trouble. The body the chemical reactions in the body just don't do well outside of that narrow temperature range that we like. So we need to act fast, and we need to act appropriately, either cooling them down or heating them up. And depending on the presentation, ask for ALS. Always, A, B, C, D, E. Yeah, get a secondary survey, get a sample history, and a set of vital signs. Okay. Water emergencies, there's a couple of these we're going to talk about. General stats, 2012 drownings by cause, 65 accidental, 49 suicide, and 33 undetermined. So between them you're looking at about 150 deaths, 147. So drowning is defined as death by asphyxia after submersion. Asphyxia being an inability to actually gas exchange. Okay. Physiology of drowning, so victims enters the water and are conscious. They experience a great deal of panic and make gasping attempts to breathe. Copious amounts of water enter the mouth and the back of your pharynx, which stimulate a spasm of your larynx and your bronchospasm. So we get the whole bronchial tree goes into spasm, which means we now cannot shift air. These spasms prevent water and oxygen entering the lungs. Carbon dioxide increases while your oxygen decreases and the victim becomes unconscious. They become completely submersed. The laryngospasm and bronchospasm continue after unconsciousness. Death follows by asphyxia and RVF. And at that stage we get a relaxation of all these the whole bronchial tree, and it's only then we have the ingress of water into the lungs. So types of drowning, we're going to have a chat about a couple of them there. So we have near drowning, dry drowning, freshwater drowning, saltwater drowning, and secondary drowning. And we're just going to mention just a little bit on each of these. Okay. So near drowning, a patient is rescued before the point of death. So they go in, they panic, they get this bronchospasm and this laryngospasm, they get a spasm of the bronchial tree, they can't breathe, but before they go unconscious, they get hauled out of the water. Okay. So this is a near drowning. Always need to be cautious that they don't have water in their lungs, that they didn't take any water in. Submersion, panic, struggle, laryngospasm leads to hypoxia, leads to death. We then have water aspirated and we'll have a nosy at these. Okay. The alveoli himself, in fresh water, the alveoli washes away the surfactant, which is the oily fluid that keeps the alveoli inflated. Once that's washed away, the alveoli collapse. Ventricular fibrillation occurs at this stage. Salty water, so this is the difference with salt water and fresh water. Salt water, what salt water does is, not only does it wash away your surfactant, but water follows salt. So if you have a piece of chicken on your plate, and there's water on it, you know, the way you have a frozen chicken, if you put salt around the outside of the plate, that water will actually go away from the chicken and head for the salt. Because water follows salt. That's just how it is. So if we have salty water surrounding the lung itself, what it will do is it will draw fluid out of the lungs itself and cause this pulmonary edema that can happen, or secondary drowning. So we're going to have a bit of a chat about that. So secondary drowning. So the victim has successfully been rescued. So they may very well have gone into the water. They may have been pulled out. They may have taken aspirated water into their tummy or into their lungs. They've been successfully rescued. Pulmonary edema or hemodilution occurs and death may follow up to 72 hours later. What does that mean? If a lot of water goes into the patient's tummy, it will start to get into the bloodstream over a period of, 20, 30 minutes. What this does with huge volumes of water, it hemodilutes the blood. It dilutes the blood down so it's watery, if you want. Okay, this can cause death. Change body pH and just screws everything up. The other thing that can happen is, particularly with the likes of a saltwater drowning, is if we get salt water down on the lungs, what it does is it draws fluid from the surrounding areas into the lung itself, and we get this pulmonary edema, and we get what's known as a secondary drowning. So the secondary drowning can be from a dilution of the blood because we had water in the tummy, or it can be because we get a pulmonary edema, so a lot of water in the lungs itself because salty water has got in, and salt drags water from wherever it is towards itself. Okay. Complications which may accompany a near drowning: hypothermia for sure, alcohol can most likely be on board, and prolonged immersion collapse. So if people are in water for a long time, pressure changes create big issue when we haul them out. Submersion incident has its own CPG, which is why we're talking about it. There's quite a bit of stuff in it, and you need to have a look at it and have a read through it. Okay. Ventilations may be commenced while the patient is in water if you're a trained rescuer. Remove the patient from liquid provided it's safe to do so horizontally. Spinal injury indicators: think about diving, trauma, water slide use, or alcohol intoxication. Higher pressure may be required for ventilation because of poor compliance. If the patient has a lot of water in the lungs, you may need to put a lot of pressure on a bag and mask to actually ventilate them to overcome the pressure in the lungs. So you need to think about these. These are questions that come up for your exams. Okay. DCA, decompression illness. So we're going to have a bit of a chat about this. So this is your typical scuba diving stuff, and there's a couple of questions pop up on this guy too. So recognizing the signs and symptoms of decompression sickness. Discuss the management of a patient suffering from decompression sickness as per the CPG. So this is kind of sort of what we're talking about. due to the formation of nitrogen. So what does it mean? Let's have a look. Let's have a quick look at this. For those of you who aren't scuba divers, or for those of you who know anything about it, air is made up of oxygen, we'll say 20%, nitrogen, 78%, and rare gases, neon, freon, argon, blah, 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 and water vapor, 1%. The majority of air that we breathe is 78%. When you take air at the surface, we're at 1 bar or 1 atmosphere as we're standing here or sitting here in our room. When we go into water, every time we go down 10 meters in water, we go to another bar. In other words, when we have 10 meters of water above our head, the atmosphere is there's twice as much pressure on our body as there is at sea level. So we go down 10 meters. We're now at 2 bar, which means if I have 1 liter of air at the surface, I now have a half liter of air at 10 meters because the air has been crushed to half its size. Yeah, and if I go down another 10 meters to 20 meters, I'm now at 3 bar. And I go down another 10 meters, I'm now at 4 bar. If I'm ascending from 50 feet or from 50 meters, I'm at 6 bar. Which means if I have, one liter, I now have 1/6 of a liter. At pressure, air gets crushed. So if I take a breath at 20 meters and I hold my breath as I ascend, or I ascend too fast, that air is expanding. It's expanding at an exponential rate until I hit the surface. What this means is, normally it's the only gas that enters my bloodstream via my lungs is oxygen. However, if I put a diver at depth for long enough, or they come up a little too quick, what can happen is nitrogen can actually pop across the barrier into the blood. And it then becomes an air embolus, a nitrogen embolus. So it just pops around as a nitrogen bubble. But remember, as you come up, what happens to that little bubble? It starts to get bigger, and it can lodge in a joint, it can lodge inside, and this is typically known as the bends. The bends is basically where we have nitrogen dissolved in our blood that does not come back out of our lungs like with the carbon dioxide to be expelled. And the cause of this is the diver ascends too quickly, or the diver has spent too long at depth and he can't actually get rid of the nitrogen out of his blood. The treatment for it is to take them to a decompression chamber, and they hop into this chamber, and basically the pressure in the chamber is upped until they're kind of at the same depth as what they were, and they're brought up slowly. Yeah, as pressure is let off really, really slowly. So, decompression sickness, due to the formation of nitrogen bubbles in the blood during ascent. So if you ascend too quickly or you spend too long at depth, nitrogen bubbles can get into your blood. The deeper and longer the dive, the increased risk. Symptoms are apparent the first 24 hours. 80% of the symptoms just actually hit on surfacing. 95% are evident within a couple of hours, really. So it's not something that's going to be manifesting in 24 hours. It's more like something that's going to manifest when they break the surface, or within an hour or so they're going to know that they're sick. Okay. So they call them signs and symptoms: the bends, the chokes, and the staggers they talk about. What does that mean? So bubbles of nitrogen can form anywhere in the body. The elbows, knees, ankles, and shoulders are typical. Yeah, they account for 60 to 70% of all DCI cases. Yeah, decompression illnesses. So they get pain in the joints, elbows, arms. Why is that? Because what we have is nitrogen bubbles stuck here, impeding blood flow, which is why we get pain. Okay. Neurological symptoms present in 10 to 15% of cases: headaches, visual disturbances. Why? Because we've most likely got nitrogen bubbles upstairs in our central nervous system, hitting the areas that are processing our sight, our speech, our areas of balance, which is why they start to get kind of, dizzy and the staggers and things like that, yeah? Decompression illness, the chokes, very rare, occur in less than 2% of DCI cases, occur in 10 to 15% of all cases. Brilliant. So, the bends, the chokes, the staggers, basically, as it progresses, the more nitrogen we have stuck in our body, the more nitrogen we have circulating in our blood, the more progressive and the more visual the illness is in the patient. Okay. So generalized weakness, apathy and tiredness, they're just knackered, they have pain. Pain, numbness, bladder and bowel incontinence, visual disturbances, reduced levels of consciousness, difficulty speaking, headaches, confusion, staggering, tremors and convulsions. So these are the kind of plethora, if you want, or broad spectrum of presentations that we get with decompression illnesses or decompression sickness. So A, B and C are managed as required. Lie them flat. Give them oxygen. They need high flow oxygen, guys. Okay. Management of acute complications. So pain management. You cannot give Entonox. Absolutely not. Entonox is completely and utterly contraindicated with diving injuries. Why? It's 50% nitrogen and 50% oxygen. So you're adding to the problem. So no Entonox. Okay. Alert ED. Decompression chambers are thin on the ground in this country, even though we're an island. I know in Dublin there's one in Strand Street, there's one in Cork, there's one in Belfast, there's one in Galway. A lot of divers on the east coast will head out to sea and make the call, and the RAF will come pick them up and take them to the Isle of Man or somewhere like that. So we need to get these people to a decompression chamber where the pressure can be kind of put on big time to take them artificially to the depth they were at, and this allows time for the nitrogen to get back out of their system. Okay. There's a decompression illness CPG, and there's quite a bit on it. So what the majority of your divers will wear a dive computer. It tells you how long you've been down. It tells you what depth you've been at. It will tell you everything about the dive. If there's two of us and we always dive in pairs, what about my friend? If one gets the bends, it's quite likely the other could develop the bends. So you will treat their friend or their colleague or their diving buddy as a potential DCI as well. Get the dive computer because it gives all the information. How long, how deep, okay? What else? Treat the supine position, absolutely no Entonox. Transport dive computer and diving equipment with the patient if possible. This is a big one here, look. Transport is completed at an altitude of less than 300 meters above the incident site, or basically above sea level. Or aircraft pressurized equivalent to sea level. So if they're being transported by heli, it needs to be pretty close to the surface. Okay, so these are questions that are commonly asked. Remember, the higher you go, the more the actual nitrogen is going to continue to expand, like going to altitude. If you've ever looked at a packet of crisps at altitude, at whatever 30,000 feet, the bag looks like it's going to burst. Why? Because the gas in the bag is actually expanded because there's less pressure acting on it. When we go below the surface, the pressure increases, and that bag will be half the size it is, you know, at the likes of the surface itself. So it's about pressure. Boyle's law, Charles's law. Anything else? Recompression. So treatment is completed at an altitude of less than 300 meters above the incident site or the aircraft pressurized to sea level, or via a transportable recompression chamber. I don't believe there's any in Ireland. Transportable recompression chamber. 100% oxygen during transport. 5 minutes air break for every 30 minutes. Yep. Where possible, recover and transport a dive computer. Always. It's always about getting information because it allows the guys to run the science on how much nitrogen is potentially in the patient system. It tells them definitively how long they'll need to, how deep they'll need to send them in the recompression chamber and for how long. Okay. Any questions? So there are no stupid questions. Usually. I'll leave this one with you guys. There's a good session on this in a classroom. So this is an introduction to it. Have a good look at it. Thanks.